I don't think so. I almost felt that. Which one? It's not like that, but I know. Yeah, I don't like that. I could always just give it to like Cassie or my mom. I feel like if she, my mom can like do and she gets like the little like things.
More class today. Is it the snow or is it the 3.0 going away? Okay. Good morning.
Good morning.
Yeah, that was a bit weak. Good morning.
Good morning.
Thank you. And we don't have to do it again next class. You've got me for the rest of the time in Patho. We've got sort of 50-50 split between renal and respiratory or respiratory. Okay. Pulmonary, whatever. Before we start, a few things. Quiz. The next quiz can either be next Tuesday, right, or the following Tuesday, so the 20th or the 27th. Your next exam is the week of the 27th, so on the Friday. So, you know, it could be that if you do it on the 27th, it's going to help you with your studying for the exam, or you may want to get it out of the way next Tuesday before you go on Thanksgiving break. So, how many for next Tuesday on the 20th? Okay. How many for the 27th? Okay. It's the 20th. Okay.
It'll be over everything after the exam to now?
Boy, there won't be enough renal classes for me to give you 5 questions. So it may be 1 or 2 from Dr. Richards and 3 from me, or 4 from me and 1 from him, something like that. So the last neuro classes, let me post an announcement to let you know which class it is. Okay?
Thank you.
Yeah. What's that?
Thank you.
Okay. Zoom did not work for Dr. Richards yesterday. I was asked if we could put the Zoom up from last year. The answer is no, because we didn't start Zooming until last spring. So we have Zoom recordings for 312, last spring's semester course. We do not have Zoom recordings from fall 2017. Okay. If you would like to talk to him and persuade him to do that, sure. Yeah, I would do that. But yeah. Okay. The other thing is, and I was going to mention the 3.0. So you've all seen the email. We've been urged for you to continue to, make the same effort, not slacken off. The question I have is, and I'm not sure about this, there were 2 changes that were made at that time. One was the 3.0 for progressions. The other was making 73 or a C a passing grade for each course. And I'm not sure where that second one stands at the moment, because the passing grade for Patho used to be a 60, a D, right? But it was increased to 73 along with the 3.0 for progression. So I'm not sure where this 73% stands for passing of each course. I will find out. Okay.
I think in the email it said as long as we have a 73, they consider us good.
That is for progressions, right? So you have to. What's that?
Not necessarily for needing remediation.
Well, or 73 for passing a class. It's for 73 overall, 3.0 GPA for progressions from one year to the next in pharmacy. Okay.
So what's our now new GPA that we have to achieve?
What's that?
It's a 73.
A 3.0. 2.0. Yeah.
2.0.
Yeah. Which is 73. Okay.
Is that for the semester or for the year?
It'll be for the year. Yeah. Yeah.
from here on out, like every year for us, or are they going to switch it to 3.0 next year?
Well, I don't know. I don't think so. I think once you, I'm not going to answer that. I don't know.
We're the schedule,
Okay.
so they're playing around with us.
Okay.
That's so nice
I
of
wasn't
them.
gonna say the redheaded one.
Okay. Kidney. Any questions before we start? Did you all do the kidney in anatomy and physiology?
Yes.
Okay. So you should be familiar with a lot of this. Okay. Two guys here who are sort of instrumental in some of the early work on the kidney. So William Bowman, so Sir, he must have been English, and then Friedrich Gustav Jakob Henle. Where do you think he came from?
I'm betting sure.
I'm guessing Germany. I'm not sure, but I'm not sure. Okay.
Those chaps that take care.
Bowman's capsule and the loop of Henle. These are two real important structures that we're going to talk about today, and keep on, certainly the loop of Henle, we're going to keep coming back to, because that's really important in the whole functioning of the kidney. Not that Bowman's capsule isn't, but it's a real important organ in terms of drug therapies. This is a list of the drugs, common drugs that you will come across as a pharmacist that work through acting on the kidney to some extent, and they act in other places as well. So clearly the diuretics, most of the diuretics just work on the kidney. The thiazides, they may have some vasodilator actions as well, but ACE inhibitors, angiotensin receptor blockers, renin comes from the kidney. Renin produces angiotensin 2, aldosterone. All of these are involved in fluid, water regulation, involve the kidney. Glucose transport inhibitors, these are some new drugs that are used to treat diabetes, and they block glucose uptake in the kidney. So they act a little like a diuretic, but they're blocking glucose uptake. They're fairly effective in decreasing serum glucose and HbA1c levels. Vasopressin, it's a hormone. Again, there are agonists and antagonists that target this. Neprilysin inhibitor, this is fairly new. There's a hormone produced by the kidney called atrial natriuretic peptide. Okay. Natriuresis means excretion of sodium by the kidney. And so this hormone works to excrete sodium, which is good when you're trying to treat hypertension. Neprilysin is an enzyme that breaks down this hormone. So there's a new drug out now that prevents the breakdown of this hormone, so you can continue to secrete sodium. And then treatments for gout, some of them work on the kidney. They block uric acid reuptake by the kidney to help lower serum urate levels. So real important target pharmacologically. We're going to start at the beginning though, come back to that later. We're going to look at the blood supply. We're going to look at the structure of the glomerulus, because that's the important first part of the process here. We'll talk a little bit about the tubules and nephrons, but we'll come back to those when we talk about the iron transport. And glomerular filtration, that's sort of going to be the focus of the things we're going to focus on today. Glomerular filtration rate and how it's regulated, because this is real important to explain some of the other things that happen in the kidney further down the tubule. Okay. What does a kidney do? Regulates whole body fluid homeostasis, regulates extracellular fluid volume. The major extracellular fluid is blood. So by regulating this, it regulates blood volume and therefore blood pressure. Kidney plus the lungs, they help regulate the body pH. Obviously, it excretes waste products, toxins, things like that. It does have some other functions, got some metabolic functions, and it also synthesizes some proteins. There are some clotting factors synthesized by the kidney, erythropoietin. It's also involved in vitamin D activation. Most of the body's proteins produced by the liver, but there are a few produced by the kidney. Some basic concepts that we will keep coming back to. This is basic physics or some physical chemistry. Ions and solutes. So iron, sodium chloride, things like that. The solutes, glucose, amino acids. They move across membranes and epithelia because of concentration differences, electrical differences, really for the ions, and active transport. And again, the active transport is more ions than the solutes, but there are some for the solutes as well. We'll talk more about the primary and secondary active transport when we talk about the ion transport tomorrow. Water flows across epithelia because of hydrostatic pressures, osmotic pressures, which relates to the ions and the solutes, and colloid or colloidal pressures. This is an oncotic pressure. This is relating to proteins. So hydrostatic, osmotic, and oncotic pressures drive water. Sodium. Sodium is the key for the kidney. It's the major extracellular cation. So as such, it helps regulate the volume of the extracellular fluid. Therefore, it regulates the blood volume and it regulates blood pressure. So by regulating sodium, the kidney can have effects on blood volume and blood pressure. And a lot of the processes that we'll talk about relate to the transport and regulation of transport of sodium. Okay. Overview of the kidney. Starts with the glomerulus, and it produces a filtrate of the blood into the renal tubule. It's essentially protein-free. So there's solutes there, there's ions there, there's some other small molecules there, but very little in the way of protein. The proteins get filtered out. There's no erythrocytes. Under normal conditions, there's no erythrocytes, little or no protein. The transporters along the nephron then selectively reabsorb the stuff that's needed, wanted, back from this filtrate back into the blood. And then the water gets reabsorbed along with the solutes, plus some other mechanisms. There's old Jacob Henle described this part, the loop of Henle. This is real important in generating an osmotic gradient in the kidney that is essential for the concentration of urine. So we'll talk about the process with the ion transport. Heard of the countercurrent mechanism? Okay, the countercurrent mechanism is a process that the loop of Henle uses to generate this osmotic gradient in the kidney for helping reabsorb water. Talk about that tomorrow. And then right at the end of the nephron, come to the collecting duct, and that's where the final regulation of the water reabsorption takes place. That's under hormonal control. There's several hormones that work in this region. Don't need to remember the numbers here, just that there is a large blood flow. 20% of cardiac output goes to the kidneys. So if you've got a normal cardiac output of 5 liters per minute, over a liter per minute goes to the kidneys. And this gets filtered, or some of it gets filtered every time it goes through the kidney. About 20% of it gets filtered. Plasma volume, not blood volume, because don't forget, the cells do not get filtered. So the plasma gets filtered from the blood into the nephron, minus the cells, minus the proteins. So, solutes and ions and water. So the plasma filtrate then is about 120 mils per minute total. And as that goes along the tubule, it gets reabsorbed. By the end, you've reabsorbed about 99 or more % of what's filtered. And so your total urine output under normal conditions, healthy adults, about 1.2 mils per minute. So your urine output, somewhere between 800, 1200 mils per day. So very large blood flow, large filtration, small, and then large reabsorption and small urine output. If you think about it, the kidney does things backwards, doesn't it? I mean, any people here who, you look at stuff in your cupboard or in the fridge and you look for sell-by dates, and if it's past the sell-by date, you throw it out? Yeah? Okay. So you go to the cupboard, oh, that's old, let's throw that away. That's old, let's throw that. Kidney doesn't do that. The kidney takes the whole lot of the cupboard and throws it in the trash. And then it goes to the trash and says, oh, we need that. Oh, we need that. So, I mean, it does it back to front.
It kind of makes sense when everything is disorganized, you take it out of the cupboard so you can take a look at it.
Yeah, but you don't throw it in the dumpster. And then
Or you put it into like a small box or something.
But I'm going somewhere with this. I mean, I think there's a reason for it, because the kidney knows what it needs. And so it's easy for it to take and say, I need that. It doesn't know what it doesn't need sometimes. I mean, there are so many different molecules it does not need. It can't have specific transporters for everything it doesn't need. And so it's much easier to have transporters for the things you need and then just take that back because you need it. Okay. So this is what the kidney looks like on a sort of a growth scale. Blood's coming in this way. And so you've got the cortex, the medulla or the medulla, and then the pelvis. And this is the ureter, which goes down to the bladder. And so the blood flow's coming in here, and the nephrons, the glomerulus, and then the tubules are in this region here. They all start off essentially in the cortex, which is where most of the glomeruli are. And then they dip down into the medulla, and then eventually the collecting duct comes back down again. So it's a very sort of, they call them convoluted tubules because they're convoluted, it's up and down. So look at a nephron itself. You got the glomerulus here, Bowman's capsule, blood coming in, blood going out. You got, the first part is called the proximal tubule. You get the loop of Henle, which dips down like this. You come back up, and then you get the distal tubule, and then you get the collecting duct, which flows down this way again. And there's a reason for this up and down that we will talk about when we talk about the countercurrent mechanism. There's a couple of types of nephrons, ones that have these short loops of Henle and ones that have really long loops of Henle. And these are called cortical, these are called juxtamedullary or juxtamedullary. But the difference is these have just got a short loop of Henle, these have got a very long loop. And these with the long loop are the ones that are important in generating this concentration gradient down the medulla of the kidney. And I say, we'll talk about that tomorrow. But these long loops are real important in helping reabsorb water from the tubule.
Do both achieve that for the concentration gradient?
What's that?
Do both of them achieve that for the juxta?
Really not. The small ones, they might do a little bit, but these are the important ones because they flow down through them, almost through the medulla, and the final water reabsorption comes out of the collecting duct, and they sort of flow with the collecting duct. More tomorrow. Going to focus on the glomerulus. Oh, and okay, just been through that. There's one other important feature that we will talk about as well. It's this region here. So this is the blood in, the afferent arteriole coming in, feeding the glomerulus, Bowman's capsule, and then the blood goes out. So this is the efferent arteriole, and this is the glomerular capillaries. This is the tubule here, proximal, loop of Henle coming up here, and then it starts the distal tubule. There's this region here where you've got the afferent and efferent arterioles and the glomerulus and the distal tubule all coming together. And this has got some important regulatory functions because the cells in the tubule sense the load of sodium and chloride there, and they can regulate the flow of blood into and out of the glomerulus to try and maintain glomerular filtration rate and sodium delivery to the tubule. So this is called the juxtaglomerular apparatus. And we will come back to that because there are certain functions that are regulated by drugs and things like that that affect this regulation. Okay, so we'll come back to it. We're going to focus on the blood flow and the glomerulus more. And I say the afferent arteriole comes in, the efferent arteriole goes out. And the afferent just feeds the glomerular capillaries. When the efferent comes out of the glomerulus, it can go in one or two directions. And one direction is what they call peritubular, where it wraps around the tubules. And it just acts as a nutritional blood flow. You know, these are metabolically active tissues. They need a blood flow, and so that's the blood flow. So the efferent arteriole coming out of the glomerulus wraps around the tubule and just supplies nutrients, oxygen, things like that. It can also, you know, and some of them, it's not, you know, the vessel doesn't get to decide. I mean, it goes one way or the other. So some are peritubular, and some have this long loop, and it follows the loop of Henle. And this is called the vasa recta. And this is not really nutritional. This is to help work with the loop of Henle to generate this concentration gradient. And so these two routes of the vessels are both real important functions, but different functions. I say one is nutritional for the tubule, the other is part of this mechanism for generating the concentration gradient to help reabsorb water further down the kidney. So, glomerulus filters the blood. And so this is the afferent arteriole, blood coming in. This is the efferent arteriole, blood going out. And in the middle here, you've got a capillary bed. This is the glomerular capillaries. This here, if I put the red circle around it, is again the juxtaglomerular apparatus. You've got the afferent and efferent arterioles, the distal tubule, and part of the glomerulus here. So this is a real important regulatory function. One of the reasons is that these cells here, the juxtaglomerular cells, are the source of renin. Renin is the precursor for angiotensin II, which is or stimulates the production of aldosterone. So the initiating factor, renin, for the renin-angiotensin-aldosterone system comes from these cells in the afferent arteriole, which are part of the juxtaglomerular apparatus. So there's control mechanisms that regulate the output of renin, therefore regulate the output of angiotensin II and aldosterone. Okay, we'll come back to that. So if you look at the capillary bed here, it's real leaky. So the capillary endothelium, which is the layer of cells on the vessel walls, they've got holes in them called fenestrations, real leaky. So fluid, solutes can get through very easily. There's a basement membrane between the capillary endothelium and the tubule epithelium. On the tubule side, the layer of cells in the glomerulus are called podocytes. And these podocytes have things called foot processes, and so something like that. So the cell is like this, and it's got holes between these foot processes. So it's leaky. So the endothelium's leaky. The first layer of cells on the tubule epithelium are leaky. Makes for a leaky system here. And so ions, water, solutes can be freely filtered across these membranes. In the interstitium, with the basement membrane, there are cells called mesangial cells. These are contractile, and what they can do is they can alter the size of the glomerular capillary bed. So they can alter the surface area that is available for this filtration. So a little more detail might help make it clearer. They've got a capillary here, and you've got the capillary endothelium, You've got the well, you've got a podocyte here with foot processes, and in the interstitium here, you've got a mesangial cell, which is contractile. And this may be a bit easier. So this is the basement membrane. This is where the mesangial cells will be. This is the key capillary endothelium, fenestrations here and here. And then this is the podocyte with the foot processes. So again, you know, holes between the foot processes making this leaky. So it excludes molecules above about 8 nanometers. Now, albumin is about 7 to 8. So, you know, it sort of excludes albumin, but there's another reason that albumin doesn't get filtered, and that's on the next slide. So it is real leaky. Iron's freely filtered, water, solutes, not proteins. Oh, okay. This was just some, I didn't put this in, you don't need all these pictures, but just some scanning electron micrographs, and it makes some of these things a little easy to see. This is a picture of the capillary endothelium. Oh, look at all those holes. Complete sieve here. Okay. And these are the foot processes of the podocytes on the other side. So again, lots of gaps between them. Okay. I want more than a B on this, okay, which is not freely filtered through the glomerulus from the blood into the nephron. Sodium, bicarbonate, creatinine, we haven't talked about creatinine, glucose, albumin. Do I need to stop it?
Yes.
Please. Anybody except Eddie ready? Not ready? You ready?
I'm ready.
Okay. I saw you typing away like crazy. Okay.
No, it's not.
Okay.
That would be a lot.
Freely filtered. All the ions are freely filtered, including especially sodium. Glucose, small molecule, that is one of the solutes that's freely filtered. Creatinine, we didn't talk about creatinine, but I gave you the molecular weight, 150. That's small. Albumin is the only one that's not freely filtered. You talked about measuring glomerular filtration rate yet and kidney function in skills lab. Okay. Creatinine is used to do that. And one of the reasons that it's used is that it's freely filtered at the glomerulus. Okay. Creatinine produced by the muscle, fairly constant rates, and so pretty constant serum levels, freely filtered at the glomerulus, not reabsorbed by the tubules. These are the things that you need for a compound to be able to measure glomerular filtration rate. It's not perfect because there is a little secretion of creatinine into the tubules, but we'll come back to creatinine and measurement of glomerular filtration rate. So glomerular filtration, blind end of Bowman's capsule, blood in, afferent arterial. You know the difference between afferent and efferent? Okay. Right. You can affect something to get an effect, right? So affect comes first, goes in. Filtration, 20% of the plasma, very leaky. Ions, solutes, sodium, creatinine, all filtered freely. Albumin is not. And then the blood out comes out in the efferent arterial. Filtration rate is really important, and there are various mechanisms that regulate it. It's dependent upon the hydrostatic pressure. So the pressure in the capillaries, the blood pressure in the capillaries is an important factor in determining the rate of glomerular filtration, or GFR. The osmotic and oncotic gradients, osmotic, ions solutes, oncotic pressure, that's protein. The pressure differences in these, can help drive glomerular filtration or not. And then the size and the permeability of the capillary and the tubule epithelial bed. You can alter the size by the contraction of these mesangial cells. The permeability is sort of fixed, but it changes in disease, and that can be a problem. You can go down in some diseases, you can go up in diseases, so that can increase or decrease glomerular filtration depending upon what happens. Filtration rate goes down in type 2 diabetes because you get fibrosis and things like that of the glomerulus, which decreases filtration. There are some conditions where you lose some of the proteins or some of the foot processes that increases the permeability and increases filtration. Pressure can be regulated by sympathetic nerves by constricting either the afferent or the efferent arterioles. There's a process called autoregulation for blood flow. You heard of that? Autoregulation? We'll talk about it. That controls the GFR. Hormones. Angiotensin II is an important regulator of glomerular filtration rate. It constricts the efferent arteriole. We'll come back to that. And there are other mechanisms where what's happening in the tubule feeds back to the glomerulus to regulate glomerular filtration rate. The important concept here. When you look at the efferent arteriole compared with the afferent arteriole, there is a higher oncotic pressure. Oncotic related to proteins. Okay. And the reason for this is because of the protein-free filtration. So just a few numbers the numbers aren't real. You don't need to remember the numbers, just the concept here. So if you afferent the blood flow into the glomerulus, let's suppose it's 100 mils and it's got 10 grams of protein. So this is the protein concentration, 100 milligrams per mil. The glomerulus filters 20% of the plasma. Let's assume that there's no protein filtration in this condition, so it's protein free. So in the efferent arteriole, you filtered 20% of the plasma. So let's assume that this is plasma, not blood flow, because you're filtering, it would only be 90, wouldn't it? But it doesn't matter. You filter volume, goes down to say 80 mils, but you've got the same protein. So the protein concentration goes up, it's higher. So the protein concentration here would be 125 milligrams per mil. So you filtered water and solutes and ions, but not protein. So the volume goes down, the amount of protein stays the same, so the protein concentration goes up. This is important because it helps regulate reabsorption from the proximal tubule. Helps regulate glomerular filtration, and it also helps solute and also water reabsorption from the proximal tubule. We'll come back to that. So, capillary bed, highly permeable. Up to about, again, you don't really need to remember the numbers, but up to about 4 nanometers, freely filtered. Anything above 8 nanometers, excluded. So between 4 and 8, it depends upon the charge of whether it gets freely filtered or whether there's some slowing down of the filtration. The glomerular capillaries have got negatively charged proteins, sialoproteins, on the surface. And so this reduces the filtration of negatively charged anions and increases the filtration of positively charged cations. Albumin is negatively charged. And so that is slowed down. The filtration of that is slowed down by the negative charge on these proteins in the glomerular capillary bed, in the fenestrations. So albumin, under normal conditions, you see little or no albumin in the urine because of this first of all, size, but also the negative charge that slows down the filtration through the glomerulus. In some conditions, inflammatory conditions in the kidney, you can lose this negatively charged protein. And so that increases the rate of filtration of albumin. You start seeing albumin in the urine. So if you lose these proteins, that is a problem for protein filtration. Autoregulation of renal blood flow. This doesn't just apply to the kidney. This applies to the cerebral vascular bed. It applies to the coronary vascular bed. There are mechanisms in place that help maintain either pressure or blood flow in a vascular bed despite changes in systemic blood pressure. Think of the cerebral vasculature. It's really important to maintain blood flow there, even if blood pressure is going up and down. So if you get massive decrease in blood pressure, systemic blood pressure, unless there were mechanisms in place, you get a decrease in cerebral vascular blood flow. What happens in those conditions is that the cerebral vascular vessels dilate. So they can increase blood flow even though the blood pressure is going down, or maintain blood flow even though the blood pressure is going down. Same happens in the kidney. And the idea is that glomerular capillary flow is maintained, is fairly constant in spite of changes in the systemic blood pressure. And if you look at the renal blood flow curve here, right? Normal range here. This is glomerular filtration. When blood pressure goes down, blood flow goes down, glomerular renal blood flow, let me back up. When systemic blood pressure goes down, renal blood flow doesn't really change over this range. And so glomerular filtration really doesn't change over this range. The blood flow only goes down at really low blood pressures, and it goes up only at really high blood pressures. But in this range here, between like 70 and a couple of hundred millimeters of mercury mean arterial blood pressure, renal blood flow is fairly constant. And so glomerular filtration rate is fairly constant. What happens in high blood pressure, what happens is that the renal vessels constrict. And this probably involves the release of nitric oxide. So high blood pressure, the vessels constrict, and so that maintains the blood flow. If they didn't constrict, higher pressure, you'd get much more blood flow. At low blood pressure, so blood pressure coming down here, renal blood flow is maintained by the vessels dilating, smooth muscle relaxation to maintain flow even though the pressure is going down. And this is probably the release of prostaglandins or hypoxic metabolites. And that's the same in the cerebral vascular bed. That's really important to maintain blood flow there in the face of decreasing blood pressure. So you get this vasodilation. So the autoregulation is to maintain flow in this vascular bed, even though the systemic pressure is really low or the systemic pressure is really high. Rafi.
Yeah. On the graph, it's arterial pressure and flow. Doesn't the kidney want to maintain from the
Say that again?
It says below 17 millimeters mercury.
Yeah.
It seems to be more.
Well, right. This doesn't extend forever. Okay. It's between. So this is the arterial blood pressure, right? The mean arterial blood pressure, and between here and here, you don't get a change in renal blood flow because of autoregulation.
That makes sense.
So once it goes too low, then the mechanisms can't complete the compensation, and so they do go down. And when it gets too high, again, they can only autoregulate so far, and it goes up. Okay, so this is sort of a summary so far. Blood in, filtered, blood out. The filtration is protein-free essentially, and the GFR is regulated by glomerular capillary pressure, the oncotic and the osmotic pressure gradients, size of the vascular bed, can alter that with contraction of the mesangial cells, and then auto-regulation of the blood flow pressure, and this helps regulate the glomerular filtration rate. Any questions? Okay. Effects on the afferent and efferent arterioles are really important because there are regulating mechanisms here, and some of these can be amplified or negated by various drug therapies. And so when this happens, then these are the drugs that can have some nephrotoxicity and problems with renal function. If you want to dilate the afferent arteriole, well, the mechanism the body uses is prostaglandins. There are two vasodilated prostaglandins, E2 and I2, and these get released locally and they can dilate the afferent arteriole. What this does is it increases the blood flow to the glomerulus, and so it increases glomerular filtration rate. So dilate the afferent, more blood coming in, higher glomerular filtration rate. If you constrict the afferent, and that's done by adenosine, that's what the body uses, adenosine. It's just the opposite. You decrease the blood flow to the glomerulus, so you decrease the glomerular filtration rate. You're decreasing the pressure in the capillaries, decrease the flow rate, and decrease GFR. Since prostaglandins dilate and increase the glomerular filtration rate, NSAIDs block this effect. So NSAIDs can have, and in fact, most NSAIDs have some renal toxicity potential. I put NSAIDs in here, only because this is a side effect of NSAID therapy, preventing this dilation of the afferent arteriole by the dilated prostaglandins. There are important effects on the efferent arteriole, and they are slightly more complex to sort of go through than the ones on the afferent arteriole. So if you constrict the efferents, and the major player in this, as far as the body is concerned, is angiotensin II. Angiotensin II, it's a really potent vasoconstrictor, and it has other effects, but it is a real potent vasoconstrictor, and that's why it's a major player in production of hypertension, cardiovascular disease, etc. That's why ACEs and ARBs, angiotensin conversion enzyme inhibitors and angiotensin receptor blockers, are so effective in treating hypertension, because angiotensin II is a major player. So if you constrict the efferents without anything else happening, you decrease the outflow out of the glomerulus. But if you don't decrease the inflow, what happens is that you've got more blood coming in, but you're constricting the outflow. So what do you think happens to the pressure in the glomerulus? Goes up, right. So the pressure in the glomerular capillaries goes up. What do you think that does to GFR? Goes up. It increases GFR, right. So increased pressure, it's all on the slide, right? Increased GFR. It increases, so this is you're increasing GFR at the same blood flow. You have an increased blood flow, so you're increasing GFR at the same blood flow. So instead of having a 20% filtration here, you're going to increase that to 30, 40%. And what that does is that produces a greater increase in the oncotic pressure in the efferent arteriole. Okay. I used to do this with some numbers, but it confused people. So let's go back to this. Okay. This is important. So we'll go through it again. So blood flow in, lose 20%, blood flow out, smaller volume, same protein, so the protein concentration goes up. if you constrict the efferent, so we're going to constrict here, what we've said is that this blood flow doesn't change, but the pressure changes in the glomerulus. So you don't have 20% filtration. Maybe you've got 40% filtration now. So this volume here is now 60 mils, still with the same protein. So the oncotic pressure is now 150 milligrams per mil. So by constricting the efferent with the same inflow, you filter more, you have a higher oncotic pressure in these efferent capillaries, which helps increase reabsorption from the proximal tubule. So that's one of the functions of angiotensin II, is to increase proximal tubule reabsorption by constricting the efferent.
Oh, you
Yeah, and go through this. Yeah, okay.
I was just curious if constriction of the afferent would, because there's a decreased inflow, but there's also decreased filtration, but would that be enough to cause the protein concentration from its normal level in the efferent to go down or to go up?
No. Constricting or dilating the afferent does nothing to the oncotic pressure in the efferent. It's You still get 20% filtration, right? It's constricting the efferent and thereby increasing the pressure in the glomerular capillaries that causes this change. Okay. Still with it so far? Okay. We're going to keep coming back to that. So let's talk a little bit about this juxtaglomerular apparatus. And it's a complex of the glomerulus, the distal tubule, and the cells here at the distal tubule are called the macula densa. And then these juxtaglomerular cells in the afferent arteriole, these are the ones that produce the renin. What happens is that these distal tubule cells, the macula densa cells, they're sort of specialized, but they're right at the start of the distal, they're at the top of the thick part of the ascending limb of the loop of Henle and the start of the distal tubule. They sense by the rate of sodium and chloride reabsorption here, they sense the amount of sodium and chloride in the tubule. And what they do is, based on this, they will send signals to the cells, the juxtaglomerular cells that produce the renin, to either upregulate or downregulate renin output. Upregulating or downregulating renin is going to upregulate or downregulate angiotensin II and aldosterone.
The macula densa is detecting sodium in the afferent or the
The macula densa cells are part of the distal tubule, so they sense the sodium and chloride in the tubule, the renal tubule, right? And then they feed back to these cells lining the afferent arteriole that produce the renin to either increase renin output or decrease renin output. We will come back. This is getting a little complex now. We'll come back. We'll start here again tomorrow, but I'll just go through the first couple of slides and sort of give you a flavor. There are two important processes that help regulate sodium, and they are called tubulo-glomerular feedback and glomerular-tubular balance. Okay, so this one, the TGF, it controls the solute delivery to the tubule, and it does this by having effects on the afferent arteriole. It says, we need more solute here, we need more sodium. So to do that, it dilates the afferent arteriole, increasing glomerular filtration rate, increasing solute delivery to the tubules, which is what it wants. The glomerular-tubular balance helps control solute and fluid reabsorption from the tubules. And this is via effects on the efferent arteriole. And so this is mainly the constriction of the efferent arteriole that we just talked about to increase the oncotic pressure, to increase sodium and therefore water reabsorption. Or you could dilate as well. So these two processes are important for maintaining the amount that's been delivered to the tubule and the amount of, it says solute, but it's mainly sodium reabsorption from the tubule. And once you regulate sodium, you're going to regulate a whole host of other things as well. We'll leave it there for today because time's just about out. And you need 10 minutes before we have our last session in drug information. Any questions? No.
What is dilating that afferent arterial?
If you dilate the afferent, then if you dilate the efferent, then you're going to decrease pressure. As long as you don't change blood flow into the glomerulus, then you're going to decrease pressure. So you will decrease glomerular filtration.
Okay.
Thanks, guys. See you in 10 minutes. Well, see you in the meantime as well, but I'll start talking again in 10 minutes.
I don't know.